The American Society of Transplantation is proud to present the latest installment of the AST Journal Club series. Today's session features the JAMA Surgery article, Survival Benefit of Living Donor Liver Transplant. The session is co-hosted by AST's Living Donor Community of Practice and the Liver and Intestinal Community of Practice. In a moment, I will turn the session over to our moderators, LDCOP co-chair, Dr. AnnMarie Liapakis from the Yale New Haven Transplantation Center, and LICOP chair, Dr. Anjana Pillai from the University of Chicago Medicine. Before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded, and the archive will be available on the MyAST website 2 to 3 business days after the live session. Please note, all of your lines have been muted so that only the presenters can be heard clearly for the archive recording. If you have a question for our panelists during the journal club, we encourage you to participate using the Q&A button in your Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the website following the journal club. Finally, when you log off at the conclusion of today's journal club, you will see a link to a short evaluation survey to complete. Please fill out this content to help us keep our content current and engaging. I will now turn the session over to our moderators, Dr. Liapakis and Pillai, to begin our presentation.
Thank you, Brian, and thanks to everybody who is joining us for what's sure to be a dynamic journal club presentation. Both of our speakers today are from the University of Colorado, where the first adult-to-adult living donor liver transplant in the U.S. was performed in 1997. Dr. Whitney Jackson, transplant hepatologist trained at McGill, Thomas Jefferson University, Cleveland Clinic, and New York Presbyterian Hospital, Columbia University, is an assistant professor of medicine, gastroenterology at the University of Colorado, where she serves as medical director of living donor liver transplantation. Whitney is an active member of the North American Living Liver Donor Innovations Group, American Association for the Study of Liver Disease, and of course the AST. And Dr. John Malamon, biostatistician trained at Temple University, Drexel University, and as a bioinformatics oncology fellow at the FDA Center for Drug Evaluation and Research, completed an FDA fellowship in large clinical trial outcomes and clinical data modeling, is an assistant research professor of surgery transplant at the University of Colorado, where he leads clinical outcomes and analytics research for patient-centric research solutions for the Colorado Center for Transplantation Care, Research, and Education. Living donor liver transplant reduces liver transplant waitlist mortality and provides excellent long-term outcomes for persons with end-stage liver disease. Yet, utilization of living donor liver transplant has been limited in the United States. In October 2021, the American Society of Transplantation held a consensus conference to identify important barriers to broader expansion of living donor liver transplant in the U.S., including data gaps, and to make recommendations for impactful and feasible mitigation strategies to overcome these barriers. The predominant theme permeating discussion and polling results centered on culture, the beliefs and behaviors of a group of people perpetuated over time. Creating a culture of support for a living donor liver transplant in the U.S. is key for expansion and includes education and engagement of stakeholders across the spectrum of the process of LDLT. A shift from awareness of living donor liver transplant to acknowledgement of benefit is the primary goal. Today, through their work and discussion of their manuscript, Whitney and John will provide education and a space to discuss within our transplant community the survival benefit of living donor liver transplant. And with that, I will turn over to my co-moderator, Dr. Anjana Pillai, who will get us started with a case presentation.
Thank you, AnnMarie. If we can advance the slides, these are our conflicts. And so we thought it would be helpful just to kind of give this context with a patient case from one of our practices. So it's a 30-year-old patient with long-standing PSC and UC who came for an outpatient follow-up visit in hepatology clinic. He has known portal hypertension. He has significant splenomegaly, very palpable, 18 centimeters, collaterals, thrombocytopenia. His platelets are low at 35K. No history of cholangitis or dominant strictures. He's really up to date on all his eval stuff as far as workup, regular workup, and he had an EGD 1 year ago, which only showed some small varices. Works full-time in construction, really not inhibited too much by his liver disease, and his MELD is 8. 2 days after a clinic visit, unfortunately, he presents to local ED with large volume hematemesis, noted to have significant anemia, undergoes the EGD, and he has large esophageal varices with the Redwell signs, undergoes band ligation, and is discharged. In the subsequent 6 months, he notes worsening fatigue with poor quality of life. He's unable to continue his work in construction. He also notices a loss of muscle mass. He had a 10-pound weight loss over the ensuing several months, and he was already a relatively thin person. His BMI was 22. And we also noted that his bilirubin started to rise from his baseline of less than 1 to 2 to 4 range. And his MELD was fluctuating, but still only 9 to 12. And so then the question is, how do we get this person an organ offer, and would living donation be beneficial in this patient, and should it be offered in this patient? And so with that, I'm going to turn it over to Dr. Whitney Jackson to start our journal club.
Better unmute. So thank you so much for having John and I here today to discuss this article called The Survival Benefit of Living Donor Liver Transplantation. I think that I can speak for both of us, just saying that being a part of this group has been really amazing. You know, we have a lot of leadership here that's been able to guide us through some of the questions that we've had clinically for a while, and to, you know, address this on an epidemiologic level. Not only do we have like amazing surgeons that are guiding us, but also some of our discussions with Bruce Kaplan, who just has such a history of experience in immunology and kidney transplant, and really with his guidance, I think came up with just some really elegant questions and some ways to answer this. So today we don't have any disclosures. I'll just go through a bit of an introduction. You know, when the final rule was implemented by the US Health and Human Services in 2000, it really mandated that allocation be based on urgency. And that's when the MELD score was adopted, which was originally, you know, developed to predict 3-month survival and to risk stratify for TIP shunt. So that was adopted. Over time, we've been talking about integration of sodium. That became official in 2016. Here within this talk today, when we talk about MELD score, we're really talking about MELD sodium, because that's what's currently being used. We know that, you know, MELD 3.0 is up and coming, and there's even some discussions about using machine learning algorithms in the future. But MELD sodium is what we'll be referring to today. You know, notably, a MELD of 15 is generally considered, you know, the minimum MELD for deceased donor offers, because of Share 15 and the fact that organs are offered nationally before they come back to local candidates with MELD scores under 15. And so, you know, I just kind of want to emphasize that it's within this urgency-based allocation system, it's probably a predictable consequence that there's a very specific role for living donor liver transplantation in the United States. Mohammed Rella has this really great article talking about the difference between, you know, the Western and the Eastern countries, and how living donor has taken shape differently at each of these places. But, you know, we know that living donor recipients have equal, if not better, survival outcomes to deceased donor recipients corrected for severity of illness. And when patients have high MELD scores and they're competitive for deceased donor offers, you know, access to transplant for these lower MELD patients is really primarily through living donor liver transplantation. And that's just the context that we're working within the United States right now. You know, it was mentioned that there was this recent consensus conference sponsored by the AST, really with the aim of identifying barriers to the expansion of living donor liver transplantation. And actually, Anjana and AnnMarie were so gracious to allow me to participate in this, and it was a really amazing experience. And one of the themes that I really heard come out of this consensus conference is that patients with low MELD sodium scores continue to experience a lack of accurate and consistent guidance concerning the ideal timing of living donor liver transplantation. And so that's really what we're trying to focus on, is coming more towards a uniform message here. I'm just going to create a framework for this because it helps me to really move forward, and also just contextualize the situation right now. In deceased donor transplantation, many of you that might be listening to this today are working on changing the distribution and allocation system, in its essence, trying to improve the justice and equity of organ allocation, and moving away from just this urgency-only based system to a system that also recognizes and prioritizes. It recognizes urgency, but it also is integrating efficiency of organ placement and utility, with the goal of prioritizing based on overall transplant benefits, putting these all together. Lung allocation has really led this, integrating utility in the form of post-transplant survival. Liver does not yet do that. Its role is really still being debated. But I think we can take that framework and think about it a little bit differently in living donor liver transplant. So many of these attributes are also important, but instead we're working under different ethical principles. Instead of justice and equity, we need to allocate a limited resource of deceased donors, and living donor, we have one donor to one recipient potentially. But because living donor liver transplant incurs a risk to the donor, we need to quantify the benefit of that donation to the recipient. In order to do so, the waitlist survival, the risk of transplant itself, and the long-term outcomes in the form of life years gained, really all those things can inform utility and overall transplant benefit. So at its extreme, you could imagine if living donor liver transplant allowed 1 month of life to be gained, there's probably very few donors that would feel that that benefit justified the risk. Whereas if in the same vein, if a donor and a recipient knew that 10 to 20 years of life years gained, well, probably most would see that procedure as really worthwhile. So I think these are components that create a framework for us to have this structure to guide individual risk and benefit discussions in living donor liver transplant. And first we have to fill in the pieces. So in order to move forward, let's just kind of review where we're coming from. In 2005, the Michigan group asked this great question: when is the optimal timing of liver transplantation to avoid harm from intervening too early and futility from transplanting too late? So they analyzed SRTR data, looking at candidates added to the wait list between 2001 and 2001 and 2003. And that was during the hepatitis C era. They found that the benefit of transplant varies across a range of MELD scores, with more benefit seen at higher range MELD scores. But you see here that candidates with MELD scores under 15 did not experience a survival advantage with transplant compared to the wait list. I just really want to emphasize that we've seen this statistical observation in the hepatitis C era inform nearly 2 decades of practice and policy. And that's really partially what motivated us to do this. We also know that based on A2AL data, that living donor liver transplant offers a survival advantage at MELD scores under 15. It's just we really haven't known where that line is to define optimal timing of transplant. So the questions that our group asked were, number 1, at what MELD scores is there a clear short-term survival benefit? Number 2, how long does it take to see that benefit? And number 3, on average, how many life years are gained? So John's gonna take over now with just showing you the overall study design and bringing you through those questions.
Yeah, thank you very much, Whitney, for the great introduction, and thank you for having us again today. I'll walk you through, again, our methodology, and we'll keep it to the 3 questions that were brought up by Whitney, and I'll take you through the results as well. But here, to orient you toward the high-level objective, we evaluated the SRTR scientific registry for transplant recipients from 2012 to 2021. And again, for clarity, we did convert everything to MELD sodium and recalculating Importantly, we binned or grouped MELD scores, as we'll get into, the way Marian et al. Did. And then we compared a population of about 2,820 living donor patients to the entirety of the wait list. And again, we're asking the question here, who gets patients who receive a benefit compared to those who do not on the wait list. Next slide. A little bit of more detail about the methodology, inclusion and exclusion criteria. I mentioned we use SRTR again for all data here. We compare patients who went on to get a living donor transplant to those who remained on the wait list. For patients listed before the use of MELD, we converted so that we're consistent. Biochemical MELD without exception point was used, and then prior transplant and multi-organ were excluded. Next slide. Great, thank you. So what you're looking at here is our population, kind of table one, if you will, of the wait list compared to the middle column, the living donor column, and then we have the total column in the third. And we looked at the 2012 to 2021 population. And beginning with age, I think you're all familiar, but we'll run through it quickly. Living donor tend to be quite a bit younger. They tend to be disproportionately, well, compared to the wait list, you see a little more female. They are proportionally overall more white than non-white. And as you can see, is consistent here with ethnicity. And then the etiologies are something that we're going to dig into a little bit due to the shift that we see, especially within the past 10 years. But we looked at alcohol, cirrhosis, NASH, and Hep C in particular. And if you, thank you. So to get further into that question of the shift that we noticed, especially in Hep C, we divided the cohort in half effectively, temporarily, and we looked at 2012 to 2015, and then we looked at 2016 to 21, which is the larger column to your right. And within that, you can see a few trends that I think are pretty striking. First, you can see that overall the wait list has a 10% increase in alcohol-related patients. And then you can see there's also a compensation here with NASH going up. And what we believe to be driving that is the eradication effectively of hepatitis C, which you can see the population in only about a 3 or 4 year median period dropped from 21 to 7.5%. Next slide. So question one, to get back into the methodology. At what MELD score, does survival benefit occur? Well, looking at the work that had been done through a long period of time, and then after assessing the population, we thought that we needed to at least recalibrate, our assumptions that have been made, and we were really, recalibrating all of them. But the first one, we wanted to look at 1 year survival short-term benefit. So we followed the 2005 Marian et al. By comparing the population, waitlisted population, to better define both risk, benefit, and timing, which we'll get into in more detail. And then just to kind of give you all the detail, we censored appropriately waitlist candidates were censored at listing, removal, death, and follow-up, and accordingly, living donor populations were censored at data transplant, death, and last follow-up. And then finally, we used the well-known time-dependent Cox proportional hazard regression to calculate hazard ratios at 1 year, adjusting for age, sex, and primary diagnosis. Next slide. So the first result, again, the 1-year survival benefit, we found that the let me go through quickly. We haven't pointed out. We have effectively 5 categories of MELD, ranging from 6 to 10, and then working over to the right, 11 to 13, 14, 16, 17 to 19, and then the 20 to 26 category. So that's the limit of what we can look at right now. But we wanted to evaluate the relative risk 1 year, the way Marion did. And we're looking at a relative risk ratio. So it's the hazard ratio is relative to the wait list. So we can see that there is no clear advantage, 6 to 10. However, we do see a shift compared to what was seen about 17 years ago. We see that the 11 to 13 group has a hazard ratio of about 0.65 and was significant. And then accordingly, you can see the hazard ratio drops. But to kind of put it into perspective here, the 11 to 13 category represents about a 36% drop in relative risk at 1 year. And then again, hazard ratio is declining as expected. Next slide. So part 2, this has to do with timing. How long does it take to see a benefit here? Again, following in the work done by Dr. Robert Wolf and Marion, we have 2 important concepts that we have been using, which are really helpful. We have equal risk, which is depicted in front of you with the arrow, and then we have equal survival. And the definition of equal risk is the time at which the risk of transplant is equal to the risk of being waitlisted at that time. And you can see that's where also the number of days where the relative risk is equal to 1, or you could look at it like it's where the 2 survival curves would converge. And then for equal survival, thank you, we have the time, the definition would be the time at which the likelihood or the probability of survival for a living donor transplant would be equal to that of someone on the wait list, of the average of the wait list. And you can see here they point to, so we calculated that by doing the cumulative sum and finding where they meet. Next slide. So here is a part of the data for our Kaplan-Meier estimations. You can see we go out to about here, just to kind of zoom in, we get to 800, but we're interested in calculating equal risk and equal survival at each MELD category. And we found, I'll just read through the table quickly. For the lowest MELD group, we found 260 days to equal risk and 270 approximately to survival. And then you can see as you go to higher MELD, that drops off, that number drops off exponentially until you get to the MELD above 20, where you're talking about within a week, you're getting back your benefit. Next slide. Thank you. And then the third topic kind of being the most difficult in my mind, how many life years are gained? Firstly, I'll say there are a number of ways to approach the question, but this question was approached in 2007, again, by the team at Michigan. And this is a fantastic paper. And it gives us a lot of insight into defining lift, meaning the long-term life years gained from transplantation. And just to briefly go over what they evaluated, they looked at approximately a 19-year cohort from 1987 to 2006. And they wanted to look at, in the end of the paper, they wanted to look at how would that project if we were to extrapolate. But the issue is that the older data, as I quoted from the paper here, were used to obtain long-term survival. But if you look as the dates run back in time, the slope at which you would calculate, right, this function is dramatically different than the one if you were to calculate it, say, 2005. The problem is that you don't have the follow-up data. So what they did is they evaluated all the way up to a 15-year period without having to impute almost any data. And we can see that their extrapolation curve lies up at a 15-year period close to about 72 or 3%. Next slide. What did we learn from that paper? Personally, I learned a lot, but at one level, although the long-term survival curve may approximate linearity, it's not linear. So we decided to go with a little bit of a updated method, if you will, here. We used a parametric nonlinear survival regression, which we like for two reasons. One, it's believed to have higher fidelity to these data, and then two, we can get a longer projection. Here we took the model out to the level, to the limit of stability, which was about 27 years. And then two, again, revealed in the paper, we talked about the lift paper. Age has a really big effect on lift. So to be careful, we removed patients that were 70 years of older at the time of transplant. And then finally, we calculated survival benefit, and we wanted to be a little bit more conservative. So we took off, we adjusted that calculation by subtracting the mean days on the wait list. Days can't be gained. Life years cannot be gained on the wait list. And again, we wanted to be more conservative in our projection. Next slide. So then the final part of the data that we're covering are the adjusted life years that we observed. And you can see that the first thing to point out is that we were not able to calculate the life years at MELD above 20. That had to do with not having enough sample. And then the first thing I'll point out is that we do see, even at the very low MELD group, 6 to 10, 13.4 life years in that group, which is a little bit surprising given that these patients have a lot longer time to equal benefit. But that's our observation. And then going from MELD 11 and above, we see significant life years ranging from 13 to 17, nearly 18, but averaging 15. Next slide. Okay, so just to summarize what we thought was important to include here, we wanted to evaluate survival benefit, both short and long term for living donor, and it just happened to be that that MELD with the data that we have, at the time, was determined to be a benefit at about a MELD of 11 to 13 in that bracket. This corresponds to unadjusted about a 34% decrease in mortality compared to being waitlisted. And then while patients with lower MELD scores have significant long-term benefit, we need to evaluate the timing and the time to equal risk and the time to equal survival. And we've found that that's also prolonged in a nonlinear fashion in the low MELD population. And again, just to highlight what the final part of the results, we found that life years in all MELD categories from 6 to 20 ranged from 13 to 17 years of life. Now, I think I hand it back to you, right, Whitney?
Yeah, sorry, I just had to unmute.
Sure.
Yeah, I think you laid it out amazingly, just what method we're using for the question and how we were able to answer that, and just really nice. Thank you. So I'll just focus on kind of strengths and limitations. I think the strengths of this are, we're adequately powered at low MELD sodium scores, which is where most patients are receiving a living donor liver transplant. the data spanning different eras. So we're making sure that the Hep C era and then the alcohol/NASH era is also represented quite evenly. We tried to do that. And to our knowledge, this is the first study to show a significant benefit in life years saved over a lifetime following living donor liver transplant. I do think that, it's important to be just transparent about the limitations. This is an epidemiologic study. It uses the SRTR database. That means that these are people who have, seen a hepatologist and a transplant team. They've been thought to have indications to be listed for transplant. And so it's really an evaluation of those patients that were thought to be good transplant candidates. This is not a study that looks at a database with all comers of cirrhosis. So I just think that that's important to really focus on. This is not fully powered to provide an interpretation for MELD scores that are higher than 26, but we definitely are seeing that survival benefit persist as your MELD keeps going up. Similarly, I think, these are things that people are really interested in, but unfortunately, we're just not powered to assess for different etiologies of liver disease. We do adjust for etiology of liver disease, so I think that helps. And we just don't have granular data on degree of portal hypertension and quality of life, which I think is also something that people are really interested in. I think the conclusions are, the role for this sort of a study is it's quantifying the risks and benefits that a lot of hepatologists think about you're sicker than your MELD score, or in aggregate, you might not, benefit from a transplant. Instead of kind of using those kind of words in our experience, this is really trying to quantify those risks and benefits to avert cognitive bias. Single patient decisions are heterogeneous, they're complex, but I think this sort of population level data can help to make some of those decisions. Clearly, we're showing that living donor liver transplant confers a substantial survival benefits to candidates on the wait list, even at these low MELD scores of 11, and life years gained are comparable or greater than any other life-saving procedure that we can think of. And then patients with lower MELD scores have a prolonged time to equal survival and would probably benefit from a post-transplant survival score to help inform shared decision-making. I can kind of expand on that a little bit just for a moment, going back to some of these examples. I'll just throw out some examples for you of how this data can be applied. So, I think our first case was a patient with PSC cirrhosis. His MELD score was 11. Clearly in that, first question, we're showing, well, around a MELD score of 11, your short-term risk and benefit, you'd probably benefit from a transplant. Somebody who's young, who's healthy, without comorbidities, without diabetes, would really be expected to gain that full potential of that median or average life years gained after a transplant. And so when you're contextualizing that, you're thinking, well, any procedure that we do to somebody has risks to it. A liver transplant certainly has a risk. That 11 to 13 range, we see that the time to equal survival is 219 days. But this is somebody who would really be expected to gain like 13 to 7 years. Somebody with a MELD score of 11, portal hypertension, complications of portal hypertension, fits easily into this to really quantify that benefit of transplant. If you want to take it to the next example, I'd think of the next example being somebody who's, maybe on the older side or has comorbidities, and you'd kind of be asking yourself, okay, well, they have a MELD score of 11. We think short-term risk benefit might make sense for this person. But say that you have a 68-year-old with diabetes or cardiovascular disease, are they going to be achieving that full average, 13 to 17 years of life? Well, they might have comorbidities that would limit that even a little bit more. And so when you're contextualizing that to say it would take 219 days for that person to achieve equal survival, is that person somebody is that person somebody who's truly going to benefit? And I think that's where this idea of post-transplant survival would really help individual decision makings. I know that post-transplant survival scores in deceased donor transplant, there's concerns like, are people not going to be adequately represented because of their age or etiology of disease and those comorbidities? But in living donor liver transplant, when you're making the best decision for an individual at any one time, I think that those kind of scores would really help us. So that's just kind of an idea of how to contextualize some of this. So when I see the future moving forward with this, just to bring it back to that framework that we had talked about, urgency is certainly important. I think we've shown, in an urgency-based system where the role of living donor liver transplant is, the risk of transplant, the life years gained. But then I know that this is what people are thinking about also. This is what we're all thinking about too. Measures of portal hypertension, how do you integrate that? Post-transplant survival scores and also quality of life. So that's a lot of where I see the future moving with this potentially. That's the end, and thank you, everybody.
Thank you, Whitney and John. That was awesome framing and a beautiful review of your work. And I'm excited to start off the conversation and questions. Just a reminder to everybody, you're welcome to post questions in the Q&A chat function. I'll start us off. I have a question. I think you really present a clear message and evidence for benefit of living donor liver transplant for candidates with the MELD sodium greater than or equal to 11. I'm wondering, how do you consider candidates with end-stage liver disease and a MELD score less than 11? Did your data allow you to explore subpopulations here who might also derive benefit?
Yeah, I think, John, you and I could probably do this together, but for me, I look at that, back in the Marion paper, they really show that hazard ratio and the error bars all above that hazard ratio of 1 in the lower MELD population under 15. Mm-hmm. In our study, we're seeing the 6 to 10, that those error bars are really crossing that hazard ratio of 1. So there absolutely are populations of people with lower MELD scores under 11 that are benefiting from transplant. I think we don't really have the power to go into figuring out who those people are. I was almost surprised that not everybody that we're listing definitely gets a survival benefit. You'd think that these are people that somebody's thought would really benefit from this. But yeah, John, what do you think about that?
We have to follow up with more sample and replication and validation. To be clear, we're not informing, we're not trying to inform policy. We're here to educate. A lot of the questions I've been answering in the technical part are valid, but the point is that we did censor at every period and appropriate period, including time of waitlist, which I answered. But we're not here to talk about whether this should be informing allocation or a model that hasn't been created. We're giving you data today that you can decide if you like or not, because that's what you'll do. And we're here to answer questions on how we did it. Now, one question, Whitney, that came up is about including deceased donor patients in the waitlist population, which is an excellent question. You want to run through that? We had a lot of talk about that early on and why we did that clinically.
Sorry, so including the deceased donor people in the waitlist population?
Yeah, I can help by reading off the question. So
yeah, sure.
An attendee wrote, I'm unclear of whether or not you censored waiting list patients that underwent deceased donor transplantation. Did you include their survival after transplantation?
Yeah, that's a good question.
Okay, so correct me if I'm wrong. I believe what we did was we're comparing the living donor recipients to the wait list. And then I think the deceased donor recipients were initially included, right? I don't think.
No, we did include, no, we did include them.
And then the deceased donor recipients, I mean, we have another paper that's looking at the deceased donor compared to the wait list also. But I think the people that did undergo deceased donor were initially included when they were on the wait list.
Exactly. And the reason we feel that that's important is that, Whitney, we kind of, you pointed it out in our last conversation, is that that gives us the ability to compare people who may not be enrolled for living donor or may change enrollment. So the question is, from just the entirety of the wait list, including deceased donor, the question is, do you derive a benefit given being transplanted? I wanted to make that clear for the audience.
Mhm. Which is really similar to at least our clinical practice here, right?
Right.
So when we are evaluating somebody for transplant, approving them to be listed, they're listed. We're trying to do everything we can to get them transplanted. So those are people that would be considered for deceased donors as they become available, DCDs. And then we're also evaluating living donors as we go too. So from our clinical practice perspective, that's pretty consistent with what our patients are experiencing.
And you agree that how often do you think you can predict for like an average patient whether there'll be a living donor or they'll get a deceased donor?
How long does it take?
No. I'm just trying to really answer the question thoroughly. From your clinical expertise, how often can you predict before a transplant or before evaluating fully a patient, how often can you predict whether they'll accept a living donor or a deceased donor?
Yeah, I
Like
think,
roughly.
sometimes we get an idea that somebody's going to have living donors come through, but yeah, like we said, we're listing them, trying to get them everything. So I don't know, a couple months maybe.
And I
Yeah.
think
So that's our
that would
perspective.
also be dependent on their MELD score, right, for deceased donor transplant, because that's gonna, dictate their position on the wait list.
Mhm.
So moving on from that question, I think you answered it very well. Next question is, so how did you account for patients who got sicker while waiting, and so their MELD score changed over time?
Yeah.
Were you able to do that?
Yeah, another great question. Thank you. We were not able to. We're working on that problem. So I'm sure the people or the person who asked that question understands that time varying and time dependent independent variables are tricky. But we did evaluate change in MELD, and we're continuing to include time dependent. But here it really did not work with the population that we had.
So I think that helps us inform that this information is really most useful when we're having discussions with our patients at the time of listing with their current MELD score and that first message that we relay to them at that point in time. That's what I take away from that.
Yeah.
So,
do you want to go ahead?
okay, I think, well, we had put this out to the LDCOP and Brian Lee submitted a question. So I'm just going to read this off of his point. He said, not being primarily involved in living donor liver transplant, Brian's in nephrology. I was told in the past that whole grafts from deceased donor liver transplant offers better outcomes than partial grafts from LDLT. Would that explain the rationale for using DDLT in patients with higher MELD scores, arguably sicker population, while reserving LDLT for lower MELD patients, aside from the way that the current allocation system preferentially favors those with higher MELDs for DDLT?
Yeah, I tried to address that a little bit in that role of living donor liver transplant slide. Brian's a nephrologist, you said?
Mm-hmm.
Mm-hmm.
Okay. I just will kind of go back to that article that Mohammed Rella did this review on, where he talks about how living donor has really taken shape completely differently in Western and Eastern countries. I think there's multiple things that go into the trends that we're seeing in living donor, but when people are being evaluated for a living donor, the higher your MELD score is, generally the worse your portal hypertension is. And so generally the larger graft size that you need. I don't agree that, survival is better with a whole graft versus a partial graft. In fact, we have a lot of data showing that survival is equal, if not better, both on the graft and the patient level, with long-term data. So I think living donor liver transplant is a really, really good option for our patients. And if anything, it should probably be the preferred option. It's just that we work in an urgency-based allocation system. So the reason that, living donors mostly in the low MELD population is really because our high MELD population has access to deceased donor organs, and our low MELD population doesn't have great access, especially with share 15. So I think it's much more a policy-based, a consequence of the policies that we've seen.
Mhm.
There's
And then-
another really, oh, sorry.
Yeah, go ahead. Go ahead.
There's another really interesting question here. Do you think these findings should inform allocations of non-directed donor organs and favor those with graded predicted life year benefit?
Yeah, we just had this controversies in transplantation conference. And this is actually something that I brought up as a potentially controversial issue that I definitely, I don't know there's an answer to it. I think it's up for debate, and it would be a really interesting debate topic. Where are we going? Are we moving away from an urgency only based allocation system to an overall transplant benefit? And then if we see that value moving that direction, you'd certainly think that non-directed donors would kind of go that way. When we, AnnMarie, you've been like, I think we've had a lot of these conversations about how non-directed donors should be allocated. There's really no policy for that right now. You think about size, you think about blood type, compatibility, and then you're thinking about like how we allocate based on an urgency-based system and who's being underrepresented and whose size appropriate. So yeah, if we're moving away from urgency only to overall transplant benefit, I think that would be really, really interesting.
And that, I wonder, could we show that, maybe that graphic one more time where you're showing the life years gained across the different MELD groups? Because I think that would be what we would be looking at. And I think they weren't dramatically different though, right? You reported that average to be about 15. Is that what you said, John?
Yeah, that's incorrect. That's correct. I would put a big asterisk on that number, though. One, in that I'll point out we did a lot of different simulation modeling for that, but we really need to evaluate a larger population to be more clear on that.
Yes, I'm just wondering if we might be a little premature to try to say that at this point in time that we would select one MELD category based on this study alone to designate non-directed donor grafts, although I do agree that it's a really interesting question, and as we accumulate more data and experience, that would be useful.
Agreed.
And John, did you want to answer this question from Dr. Lucy? So he wanted you to expand. He wanted you to expand on the previous point. I wrote a paper with Bob Marion and Doug Schobel, and my understanding is that the survival benefit included both pre and post-transplant events from the time of listing. Is that different from what you did here?
No.
Okay.
I'm not sure why that's not clear, but is it not clear in the paper or the presentation? That would be helpful. And then we could maybe, be a little more clear. We didn't get into the censoring into a lot of detail, but we did follow, to answer your question, Dr. Lucy, we did follow as best we could, the guidance of that fantastic work. And I'll have to say too, we've acknowledged it's not the same population, but if you have a suggestion on a better population to compare, I'd like to work with you to find it. But right now we have the wait list to work with. So we're providing that. But going forward, like I've mentioned, we're certainly going to validate these findings. We're not saying, again, we're being very cautionary on how people interpret the data. We're not overstating anything, I don't think. And again, we have a different population than what Bob Marion looked at, both on the wait list and the fact that they looked at deceased donor primarily, and that we're looking at live donor population. So it's really hard to compare them at a low level, I think.
Yeah, and I think he follows up. He's not being critical, just more wanted to point out that the survival benefit is valuable. Yeah. And to that point of I think what AnnMarie asked earlier, and I know we can only extrapolate so much data from this, but it's a clear message. How has this kind of changed your practice in Colorado? You guys have really increased your living donors substantially recently, and kind of how are you discussing this with your patients, as when you give them the living donor talk, how are you incorporating this?
Yeah, I think generally in the transplant hepatology community, we've talked about these low MELD patients and their risk on the wait list for a long time. And we've really seen the benefit of living donor liver transplantation. For me, this gives me a lot more confidence. It shows me that our instincts are correct with a lot of these things. It also made me a little bit less afraid of timing. So there's this kind of way that we'll talk to patients sometimes where we'll say well, maybe we can get a little bit more time with this liver, and we have to be so careful about that risk benefit decision. Is there this switch that changes at this certain time? But then when I see these MELD scores do so well, and like you were saying, the life years gain seems to be kind of consistent throughout these things. It just takes a little bit longer to see that time to equal survival. It just made me a little bit less scared. I mean, in the end, we're trying to help people. We're trying to, increase their overall survival. And so, does a MELD versus 11 versus 12 really matter? So I think it's really increased my confidence, made me a little bit less, wary of timing. And what I see happening with us, we've always been a center where we do quite a few living donors. And so it's always something that we're talking to every single patient about. But I'm noticing just these general trends where, we're evaluating people a little bit earlier. We're saying, you might not have access to a deceased donor right now, but living donor would be a great option for you. Even if we're not able to find the right person right now, let's kind of keep you on the, in the back of our minds that you'd really benefit from this at any point in time. So instead of that idea of seeing a patient doing a transplant eval and saying you're too early, saying you'd really benefit from this, it's just a matter of how do we do this.
Yeah.
Have you had the opportunity, Whitney, to take this message, this data specifically to local GI groups or your referring providers? And if you have, how have they received the information?
We're pretty, we have a very, this might not be applicable to everybody. So Colorado is really a catchment for very, very rural areas around us. Okay. And actually pretty consistently, it's been an issue for us where people who don't have great access to physicians, they might live very rurally, their primary care doctor may be hours away. So people are coming to us with pretty high MELD scores anyway. And this has always been a message that we've been trying to get out. I think the unique thing in the past couple of years is that we're really, really working on our outreach clinics. So now we have somebody who goes to New Mexico, every 2 weeks to an outreach clinic and is bringing that message. Whereas before we were hoping to kind of get that message out just through seeing patients, and we were seeing people so late. So I do think there's just a general slow change that we're seeing. Yeah.
There is one question that I'm going to ask from, I know we're short on time, but there is a question regarding, the manuscript stating that survival times for waitlist candidates started for all patients at the date of listing and then censored at the date of death or on removal from the waitlist. That's what the manuscripts currently states. And the question is, candidates that get a deceased donor are removed, but were they censored, or did you include their post-transplant survival in the survival comparison?
Yeah, I'm on right. Oh, they are included post-transplant.
Okay, thank you.
You're welcome. Yeah, thank you for the question.
I think that brings us to a nice stopping point. Want to take the opportunity again to thank you, Whitney and John, on behalf of LICOP and LDCOP. It's been a great opportunity to interact with you for this session today, and I think it's such great work and an important message for us to relay, even outside of the transplant community, to our colleagues in gastroenterology and hepatology, and now you present that data for us to be able to do so.
Yes, agreed. Thanks very much.
Yeah, thank you very much
For having us.
AST would like to thank Drs. Jackson, Malamon, Liapakis, and Pillai, and the members of LDCOP and LICOP, as well as all of our attendees for today's session. Please remember to complete the evaluation survey in Zoom and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's LDCOP and LICOP, please visit myast.org/COPS or connect directly to the individual COP hubs. Thank you all again for today's excellent session.